Welcome to GlobeWatch with me, Charles EBUNE, from the Hilton Hotel here in Yaoundé, Cameroon. Plus 40 million people globally have been infected with the coronavirus, with plus 1 million others dead. 10 months into the crisis, a crisis which began in the Chinese city of Wuhan and today has affected the whole world. Much of Europe is facing almost what everybody considers today to be a second confinement of the population, as the United States of America remains the most affected nation in the world with the advent of COVID-19, with plus 8 million people infected and plus 225,000 Americans already dead. Why are the figures of COVID-19 cases so low on the continent, whereas it was predicted to have a tsunami about the disease? My guest today on GlobeWatch is the man managing the entire African strategy against the COVID-19 pandemic. Dr. John NKENGASONG, welcome to GlobeWatch.
Thank you. Thank you for having me on your program.
Well, thank you very much. If you look at the global map today vis-a-vis the coronavirus, we are plus 40 million people infected, nearly a year since the pandemic started. Plus 1 million people are already dead. What is the epidemiological situation on the continent?
So, as you rightly said, Charles, over 40 million infected globally, over 1 million deaths, unfortunately. In Africa, as we speak today, about 1.7 million Africans have been infected. That is, if you take all our 55 member states that constitute the African Union. And of that, about close to 41,000 people have unfortunately died. Now, when we look at the situation in Africa and you compare it with the rest of the world, I mean, it seems like we are doing way better. And I think, and there are several reasons that we should pride ourselves with, but cautiously also learn lessons from what is going on in Europe.
Well, countries like Italy, France in Europe, Brazil in South America, and the United States of America, of course, with the highest number of infected people and those who have died, where the situation is very scary. When you come to Africa, which are the key zones and countries where the disease has taken the community almost like hostages?
Yeah, there's, if you look at our continent, the continent is divided into 5 geographic regions. That is the North, East, Central, Southern, and West Africa. The overall trends we see is that we are on the decline and have been on the decline since July by all regions. However, in North Africa, we continue to see a steady increase, and that steady increase is fueled by 3 countries, that is Libya, Tunisia, and Morocco. And it's very fascinating to see the epidemiologic curve in Morocco and Tunisia. Right up to August, Tunisia and Morocco were cited as best cases in my reporting each week, because their curve was very flat, but then suddenly it jumped up to about more than 100% increase there. That tells us that this is a very tricky virus. It lures you into a false sense of complacency and gives you the sense that you've won the battle, and then it springs up very quickly. If you look at Kenya, Kenya had brought down the number of cases to about 72%. And now they are back up about 71%, okay, of cases there. So I think it's very important that we continue to recognize the progress we've achieved so far, but also know that this virus has the potential of rebounding very effectively.
Well, like you said, just about plus 1 million Africans have been affected. That is a far lower number when compared to a country like the United States of America, which has plus 10 million today infected, when we know that the African population is roughly 1.3 billion people, almost the population of China. You said that roughly 41,000 people have died on the continent. When you compare it to a US with a population of roughly 360 million people, where we have had plus 225,000 people who have died. Explain to me scientifically, based on the research that you are on a daily basis receiving, why the COVID-19 cases are so low in Africa compared to other zones in the world. Scientifically, how do you explain that?
That's a very good question, and it's a question that is on the minds of many. If you recall, when the pandemic just broke out, it was reported and predicted through modeling that by this time almost 3 million Africans would have died. And I said at that time that it was a modeling and prediction. It didn't mean we have to die. It meant if we do the right things, we can prevent it. And so let me answer the question from the perspective that is backed by facts and evidence and what we don't know. The leadership of the continent reacted in a very timely fashion. I think we should recognize that. On the 14th of February, the first cases were reported in Egypt. And on the 22nd of February, through the leadership of Chairperson Moussa Faki, we convened...
You're talking of AU Commission Chairman?
The AU Commission Chairman. We convened an emergency meeting of all ministers of health. At that time, people said, John, you cannot convene ministers of health to Addis Ababa within 1 week to discuss this issue. Push it forward. We said no, it was urgent. Guess what? Over 45 ministers of health came. Even ministers that were traveling in Europe, like the Minister of Health of Nigeria, had to retour his trip from Europe to come to Addis Ababa to attend. We achieved 2 goals at that meeting. One was the agreement that we have a joint continental strategy that is underpinned by the need to cooperate, to collaborate, to coordinate, and to communicate. The second thing we agreed on was the need to have a task force, a common task force on the continent. We were the only continent to have had a continent-wide task force to coordinate and respond. And every Tuesday at 4 p.m. East African time, we regroup as a continent to discuss the pandemic. The ministers went home with clarity of understanding of what to do and clarity of understanding of the need to continue to communicate there. So when the first cases, series of countries were beginning to be hit during the first week of March, they did just what we had agreed on. That is, you lock down, because we were not prepared. Okay, we had no personal protective equipment, we had very limited diagnostics, and we had very limited what I call foot soldiers, people that could do contact tracing. So by shutting down our borders, by shutting down movement and locking down, we were able to blunt the spread of the virus. I give you scientifically an example. South Africa was doubling in the number of cases every 2 days. When they went into lockdown, they had reported just about 800 cases, and the numbers were doubling every 2 days. That lockdown had blunted that and extended that for about two weeks. The doubling period increased to 2 weeks. That is significant. Do
we consider COVID-19 as the white man's malaria? Possibly, have we been immunized in Africa because of the normal malaria we have all the time, which they say the white man cannot stay in Africa because of malaria? I mean, in colonial times. So is it COVID-19? Is it the white man's malaria? For some of us who studied history.
It's not the white man's malaria, but I think, let me just finish my thinking with...
you know why I'm using the metaphor of malaria? Yes. Because the world's first killer, and especially in Africa, remains malaria.
Yes, a combination of malaria, HIV, TB kills about 1.2 million people every year in Africa. So the youthfulness of our population has also played in our favor. I mean, the median age in Africa is about 19 and a half years. In Europe, it's more than 43 years. I think that the high number of asymptomatic people in Africa, so many people have been infected, but again, so many people have recovered. And even people who have been infected, they just run around, they are asymptomatic. So that has also helped us. That's what we know. What we don't know yet is that this is a new virus. And we are only 10 months into this pandemic. We still have to understand the genetic makeup of the virus. We now have to also understand the genetics, if our genetics is playing a role here. I think we just don't know. And that brings us to the question of, is this a white man's malaria? And I think it is not white man's malaria. I mean, COVID-19 is as lethal as it could have possibly been everywhere. Now, what we don't know about the virus in Africa is, are certain pre-existing conditions favoring us, like what you call passive immunity to other things that we have been exposed to. We just don't know. So again, only research will tell us that. I think we should have an open mind that research will provide.
You are the director of the African Centers for Disease Control. You are like the Minister of Health for the whole of the continent when it comes to research and coordinating disease prevention and management. Tell me, how do you establish the statistics? How do you collect the data vis-a-vis COVID? There is a lot of suspicion. How do you know that this is the number of cases?
No, when you, let me quote a colleague in Geneva, Mike Ryan, who said, when you count things, you miss things. So the numbers that we see there are the numbers, but are we missing, are we counting far less than the situation is? I don't think so. Are many more people dying and we don't know about? No, that's not the case. I mean, you are in Cameroon, you have family members all around and friends. I mean, you know that they are not dying in large numbers, I think for sure. So we are definitely not counting everybody, but we don't think that we are like missing the mark almost like 20%.
When COVID started, when you look at the corporate world, the global cry was that Africa did not have the necessary medical infrastructure to withstand a large-scale spread of the disease, that we needed extraordinary financing. When you look at the resources that have been made available through fora like the Global Alliance on Vaccine, is it more of a continentally driven financial or medical assistance, or one that largely comes from the outside world?
It's both. I think, let me start with the continental strategy, which is very important.
How much did they mobilize, for example?
Yeah, the President Ramaphosa, who is the current chair of the African Union, established a series of economic invoices. Dr. Ngozi, Dr. Donna Kaberuka, and others, Tidiam Cham, and gave them just that.
Kaberuka, the former African Development Bank president, Ngozi Muela Ogonjombi from Nigeria, former finance minister.
Exactly. So they are all there doing just that. That is mobilizing and talking to the IMF, the World Bank, and other financial mechanisms, bilateral and multilateral, to raise resources, economic resources that will be needed to not only fight the pandemic, but also stimulate the economy. I think they have been extremely successful in that. The need is that Africa would probably require about $100 billion over the next 2 or 3 years to boost its economy, and they are working very hard in that space. He has also established, President Ramaphosa, again, the chair of the African Union, what he called the COVID Fund, Response Fund. And it's managed at the African Union, where member states, private individuals, and other private sectors are contributing extensively to the fund. And we use the fund in doing two things: to distribute or procure common commodities.
How much do you have in now? Is it enough?
Yeah, we don't have enough, but that drive, just last weekend, we were in a very massive campaign to mobilize additional resources. Like government of Cameroon has contributed $2 million to the fund, and many other countries have contributed. So it's an ordinary expression of solidarity within the continent that has never been seen before. I think that is mobilizing those resources there.
The resources mobilized, when you look at the benchmarks, the health situation of Africa in the midst of COVID, the complaint has been that people are escaping the hospitals. I don't know what you are doing at the African Centers for Disease Control to work on this medical psychology, which has been instilled on the people.
Absolutely. When you have any disease, a new disease that people die, and there is no effective treatment, no vaccine, there's a tendency to be stigmatized, and there's a tendency for discrimination. And all of that is driven by the fear factor and the vulnerability factor. I think that is what is very understand now. The politics and policies must be aligned so that the community is assured, and the community and the civil society must be and should be part of any integral response. I call that the whole of society approach to responding to COVID-19. COVID-19 is in the community. So the fight will be won or lost at the community level. And we have to empower the community so that they lead the response and that they manage the response and own the response at the community level.
What has been the role of the African Centers for Disease Control in establishing a continental protocol, the best practices?
Absolutely. We have put out more than 40 guidance documents. And if you go to our website, africacdc.org, you see more than 40 protocols and guidance documents that have been put out there and distributed through note verbals to member states. And again, if you recall...
Are they applying it? Are you satisfied with the degree of application?
They're applying it. They're applying it because we do...
Taking into consideration their own country realities.
Exactly, because those guidance are now, they need to be adapted locally in the local context, but at least the overall guidance framework is established, and WHO is putting some. We coordinate with the World Health Organization as well.
One element which Africans have been priding themselves of COVID-19 is the use of African traditional medicine. Mm-hmm. Is it really a window of opportunity? Where is the project from Madagascar? That is where I'm heading to.
Yes. Let me start with the traditional medicine piece. If probably you're aware that the Africa CDC and the World Health Organization office in Brazzaville, we issued guidance and we've established a task force to work uniquely on that, on the traditional remedies in Africa, and come out with specific guidance and also promote it as much as possible. Not just in the context of COVID, but use COVID as a driver so that we have there are two things that we should look at, actually always be conscious of and promote with respect to traditional medicine is the safety, the standardization, and the effectiveness, actually three things of that. So that we have a standard way of approaching it, and then that would deal with the claims. If you recall, after any outbreak, there are people who claim they have this or that remedy. Those are three milestones we should be checking each time they claim that. So if they have a roadmap to apply themselves to appropriately to ensure accountability.
So the Madagascar project and that of Archbishop Cleda in Douala, at least the ones which were continentally heard of, are we using them privately and we don't want to publicly declare them in our public health system as usable and good?
Yeah, let me speak to the Madagascar situation because I know it very well. I have engaged with the government of Madagascar at the highest level, and they have sent me all the data that exists. We've reviewed it, and we are working very closely with the World Health Organization in Brazzaville to engage them so that we can really do a formal clinical trial of them. Now, when the claim was made by the head of state of Madagascar, we just didn't have enough evidence and data to support it and to put a stamp of approval or endorsement to it. And clinical trials have not been conducted in an independent fashion to really establish the effectiveness and also the safety of the drug. So it doesn't mean it doesn't work, but we are saying we need due diligence, and which follows basic scientific protocols to establish that these two parameters are met.
Just tell me, what has been the scar of COVID-19 on other diseases in Africa? Have we forgotten the fight against HIV and AIDS? Have we forgotten about malaria? Have we forgotten about tuberculosis? Have we forgotten about measles?
That's a very good question, Charles. When we developed our continental strategy way in February, we designed it in three pillars. The first pillar was to limit transmission. The second pillar was to limit deaths. And the third pillar was to limit harm. And harm there was designed to mean harm to the economy and harm to other diseases, like the HIV, TB, and malaria. I mean, as you stated earlier, the HIV, TB, and malaria collectively kills over 1.2 million people a year. There's absolutely no doubt that in every pandemic or an outbreak, like what happened in West Africa in 2014, those programs tend to suffer.
You are talking about Ebola?
Ebola outbreak, yeah. Those programs tend to suffer. And I think it is very possible that if countries do not really in a very deliberate manner, continue to implement those HIV, TB programs. Just in HIV, we may be seeing an excess of another 500,000 deaths just due to HIV, which are the indirect impact of COVID-19. So I think it is my appeal to all member states that they continue to keep an eye on their HIV programs, their malaria programs and TB programs, and very importantly, the immunization programs, because that is where those are the programs that are most vulnerable.
We are talking about the vaccination of children. But you know the skepticism of vaccination in Africa.
Well, there's skepticism, but I really want to be sure that the entire community understand a few facts, that we as Africans have survived all these multiple diseases, the introduction of new diseases since 1970 to present because of effective vaccines and safe vaccines. Myself, I think I've received more than 10 vaccines, tetanus vaccines, yellow fever vaccines, and all kinds of vaccines. And I think it is thanks to those vaccines that our children are alive. Vaccines are the most potent public health tool that we have, and they are safe, they are effective. This is not, this is based on science, I think, since the first vaccines were produced many years ago. So if we allow that movement, the anti-vaccine movement, to seed into our communities, it will become very difficult. I always say that you can have a vaccine, but without vaccination, you have no vaccine.
Okay. Well, the Cameroon Academy of Science a few days ago recognized you with the African Centers for Disease Control for the tremendous work you are doing in driving the right strategy, the right message for the health of the continent to be sustained and maintained. What other value additions have you received as an achievement?
First of all, let me express my sincere appreciation and gratitude to the Academy, the Cameroon Academy of Science. We were not expecting it. I was not expecting it. And very personally, to have received that award that is named after a renowned scientist like Professor Victor Nomangu was humbling. And I truly appreciate that recognition, and especially coming from Cameroon, my native country. I left this country at the age of 24, never been back to work here, but I met Professor Nomangu very early on in my career when I was probably around 23 years, where I went to his office to ask him for guidance whether it was more valuable to read entomology, that is the study of insects and the impact on diseases or plants, or to read virology. He looked at me. It was very humbling experience, because he was such a towering, respected figure. And he sat me down, and when my heart was pumping in my chest, he said, "I think, young man, virology will be more exciting." And that stuck. And I went on to read virology, and I've been practicing public health virologist now for 32 years. So I'm very grateful for that award. The Melinda Gates Foundation, as you probably have heard, also recognized the tremendous work that we did in coordinating the continental response, the work that we are doing to advance access to vaccines, what we call equitable access to COVID vaccines. And in March, they recognized me with the award they call it the Global Goalkeeper Award.
When you look at the map of Africa, each time you spread it on your table, you are in a plane, you are moving as a virologist, thinking, discussing with health policy makers and others. What do you source out as the greatest health challenge on the continent?
The greatest health challenge on the continent are twofold. That the frequency of emergence of infections is increasing because our population is increasing. Remember, at independence, the entire population of the continent was perhaps less than 300 million people. And today, we are a continent of 1.3 billion people. And when you talk of a large movement of expansion of population, you also think of diseases, because people are moving quickly, faster. That is important. Second, you look at the population dynamics, the movement from the remote areas to the capital cities, urbanization is going to change the dynamics there. That leads to emergence of disease. From 1970 to now, look at the new diseases that we are facing as a continent. HIV was not there when we got independent. Ebola was not there when we got independent. COVID-19 was not there when we got independent. The chikungunya virus, so they are emerging. So the continent has fallen short on three things. We are not developing our own capacity to produce vaccines enough. We are depending exclusively, almost entirely, on foreign nations to produce vaccines for our health security.
Johnson, Pfizer, Sanofi.
All of those are Western companies. Our basic vaccines are produced essentially from India. We import nearly all vaccines, with the exception of Pasteur Institute in Senegal that produces yellow fever vaccines. I think there's another vaccine production site in Egypt. We just fall short of that. Drugs, we import almost 90% of our drugs from outside the continent, okay? And diagnostics, until COVID hit, there was no country in Africa that was producing a simple diagnostics, a simple rapid test for anything. But remember, Charles, we have lived with HIV for about 40 years, and every year we do conduct about 150 million HIV tests, but there's no company in Africa that produces a simple rapid test for HIV. That has to stop. So that is what I'm calling a new public health order for the continent, where the continent looks inward and begin to produce those cornerstones and ingredients that will help us protect ourselves in the spirit of a new public health architecture that will ensure the safety and the guarantees of our lives.
The director of the African Centers for Disease Control with headquarters in Addis Ababa, Ethiopia, Dr. John NKENGASONG, thank you very much indeed for being guest on GlobeWatch.
Thank you. It was a pleasure.
You're welcome.
Thank you.